Here is a detailed comparison of 15 key differences between hypertriglyceridemia and homocystinuria. Definition: hypertriglyceridemia, a condition characterized by excess triglycerides in the blood, usually above 150 milligrams deciliters. Triglycerides are a type of fat, lipid, that stores energy from the food we eat. Homocystinuria, a rare inherited metabolic disorder where the body is unable to properly process certain amino acids, primarily methionine, leading to the accumulation of homocysteine and its metabolites in the blood and urine. 2. Primary cause: hypertriglyceridemia often results from lifestyle factors, e.g., high-fat diet, obesity, diabetes, excessive alcohol intake, though it can also have genetic origins like familial combined hyperlipidemia. Homocystinuria, caused by genetic mutations in enzymes involved in the metabolism of homocysteine, especially cystathionine beta synthase, CBS, deficiency. 3. Metabolic abnormality. Hypertriglyceridemia involves dysregulation in lipid metabolism, particularly an excess in triglyceride production or reduced clearance from plasma. Homocystinuria involves defective amino acid metabolism, particularly in the transsulfuration or remethylation pathways affecting methionine and homocysteine. Biochemical marker: hypertriglyceridemia, elevated serum triglyceride levels, often 150 milligrams per deciliter, severe cases 1,000 milligrams. Homocystinuria, elevated plasma or urine homocysteine and methionine levels, abnormal sulfur-containing amino acid profile. 5. Clinical manifestations. Hypertriglyceridemia may be asymptomatic initially. Severe levels can cause pancreatitis, xanthomas, hepatosplenomegaly, or increase cardiovascular risk. Homocystinuria presents with developmental delays, intellectual disability, ectopia lentis, lens dislocation, long limbs and fingers, marfanoid habitus, osteoporosis, and thromboembolic events. 6. Inheritance pattern. Hypertriglyceridemia can be polygenic or due to autosomal dominant mutations, e.g., familial hypertriglyceridemia, but is often acquired. Homocystinuria, a monogenic disorder inherited in an autosomal recessive manner. HA7. Hypertriglyceridemia can occur at any age but is more common in adults, especially with risk factors like poor diet, obesity, or diabetes. Homocystinuria, usually diagnosed in infancy or early childhood, especially in populations with newborn screening programs. 8. Diagnosis. Hypertriglyceridemia, diagnosed via a fasting lipid profile, which shows elevated triglycerides. Homocystinuria, diagnosed through plasma amino acid analysis, urinary organic acid test, and confirmed by genetic testing for mutations in the CBS gene or other involved genes. 9. Treatment approach. Hypertriglyceridemia, lifestyle changes, low-fat diet, weight loss, exercise, medications, fibrates, niacin, statins, omega-3 fatty acids, managing comorbidities, diabetes, hypothyroidism, homocystinuria, vitamin therapy, pyridoxine B6, B12, folic acid, dietary modification, low methionine, protein-controlled diet, betaine therapy helps in remethylation of homocysteine to methionine, anticoagulation to prevent blood clots. 10. Complications. Hypertriglyceridemia, acute pancreatitis, especially if triglycerides 1,000 milligrams, atherosclerosis and cardiovascular disease, hepatic steatosis, fatty liver. Homocystinuria, thromboembolism, stroke, pulmonary embolism, skeletal deformities, eye abnormalities, lens dislocation, neurodevelopmental delay. 11. Genetic basis. Hypertriglyceridemia, often multifactorial. Familial forms include lipoprotein lipase deficiency or ApoC2 deficiency. Homocystinuria, caused by mutations in genes like CBS, most common, MT methylation pathway, MTR, MTRR, affect folate metabolism. Management focus. Hypertriglyceridemia, focus on reducing triglyceride levels, preventing pancreatitis, and cardiovascular risk reduction. Homocystinuria, focus on preventing metabolic complications, reducing homocysteine levels, and managing developmental or systemic issues. 13. Prognosis. Hypertriglyceridemia, good prognosis if well controlled. Uncontrolled levels increase risk of lifelong cardiovascular complications. Homocystinuria, prognosis varies. Early diagnosis and treatment significantly improve outcomes, but late diagnosis can result in permanent damage. 14. Screening recommendations. Hypertriglyceridemia, adults 20 years, routine lipid screening every 4 to 6 years, more frequent if at risk, obesity, diabetes. Homocystinuria, included in many newborn screening programs, also screened in children with developmental delay or thrombotic events. 15. Long-term monitoring. Hypertriglyceridemia, periodic lipid profile tests, monitoring for cardiovascular risk factors. Homocystinuria, regular plasma homocysteine and methionine levels. Monitoring growth, cognitive development, summary table, feature hypertriglyceridemia, homocystinuria, homocysteroids, and IFEEN, definition, elevated blood triglycerides, inherited defect in methionine metabolism, cause, lifestyle genetic, autosomal recessive enzyme deficiency, key molecule, triglycerides, homocysteine, biochemical marker, high triglyceride level, high homocysteine methionine. Onset, often adulthood, early childhood, symptoms, pancreatitis, CVD, lens dislocation, thrombosis, mental delay. Diagnosis, lipid profile, amino acid analysis, genetic testing, treatment, diet, fibrates, omega-B6, folate, diet, betaine. Risk of CVD high, high due to thromboembolism, genetic basis, often polygenic, monogenic CV, etc. Screening routine lipid testing, newborn screening, varies by country. Inheritance, may be inherited or acquired. Autosomal recessive, prognosis, good with control, better with early diagnosis and treatment. Major complication, pancreatitis, heart disease, blood clots, developmental issues, management. Focus, lipid control, homocysteine reduction, and symptom control. Let me know if you need a comparative chart or simplified notes for study purposes. Thank you. Have a nice day.